Good evening, everyone, and welcome to the 2024-2025 Sports Medicine Webinar Series. My name is Michael Rogers, and I'm a research fellow in the Orthopedic Department, and I have the privilege of being the moderator for this evening. We are joined today by a very special speaker. He is the chairman of the Department of Orthopedics, medical director of the Orthopedic Oncology Program, and program director of the Morristown Orthopedic Surgery Residency Program. He is board certified in orthopedic surgery by the American Board of Orthopedic Surgery. He is responsible for ensuring outstanding quality, academic excellence, and optimal operational performance across Atlantic Health System's 6 hospitals. He is one of approximately 150 orthopedic oncologists in the nation. His work treating and researching pediatric and adult patients with bone and soft tissue cancers and benign tumors and metastatic cancers is internationally recognized. He is actively involved in clinical research, about which he lectures and publishes frequently. One of his many notable publications that he wrote and co-edited was Techniques in Orthopedic Surgical Oncology, which is the sole textbook that details surgical procedures in orthopedic oncology. Ladies and gentlemen, I'd like to introduce you to today's speaker, Dr. James Wittig.
Hi, everyone. Welcome to the lecture. Today, we're going to talk about musculoskeletal tumors masquerading as sports medicine injuries and other conditions. And this is an important topic. I often see as an orthopedic oncologist, many patients who go undiagnosed for a significant period of time because their tumor was dismissed as a sports medicine type injury, or they recall some sort of injury in the past that was really a red herring. So musculoskeletal tumors are really infrequently encountered in your practice, in a primary care practice. The clinical presentation may be confused with a sports injury, and patients often who have tumors recall an injury and complain of pain, swelling, often they feel that they pulled a muscle or that they have a muscle strain. Many times they're diagnosed as having a knot in their muscle or having night pain or having growing pains. And these are often red herrings and lead you down the wrong path of diagnosis. So an accurate diagnosis really requires a high index of suspicion and proper imaging. In terms of musculoskeletal tumors, we have primary cancers of bone and soft tissue. These are called sarcomas. Sarcomas arise from the mesenchymal precursor stem cells, and they form in your muscles, your bones, or your connective tissues in the body. We have patients can present with pathological fractures. We can have metastatic cancers that can develop into pathological fractures. There are intraarticular tumors, periarticular tumors, soft tissue sarcomas. There are cyst-like tumors that can look like a cyst on an MRI or palpate similar to a cyst. And sometimes you can actually have 2 conditions going on at the same time. You could have a sports medicine injury or some other type of injury and actually a tumor at the same time. Sometimes a tumor is actually, or a malignant tumor can actually be caught early because the patient experiences some sort of an injury. So what's the clinical presentation of bone tumors? Most malignant bone tumors are painful. Pain at night and at rest is worrisome. Right? Many patients will complain of pain at night that keeps them awake. Many are associated with swelling, especially when the tumor penetrates the bone into the soft tissues. And almost everybody can call an injury, and often that injury may be a minor injury and may be remote many months in the past. Patients can sustain an injury and be found to have a tumor. They can get into a car accident and have an X-ray of a body part. And many times it's an incidental finding, but sometimes they are serious incidental findings. Patients can have an injury or complain of pain in one body part and a tumor in another location. Patients can even present with a pathological fracture. So the tumor may be growing or could have metastasized to the area, and they fracture through it. And always remember, the mechanism of injury must justify the fracture. Have a high index of suspicion. So for instance, if you had a child sliding into home base and they break their femur, they really shouldn't do that sliding into home base. It should take a very substantial trauma to fracture a child's femur. Here's an example of a malignant bone tumor, and malignant bone tumors can be very permeative in nature. If you don't have the proper contrast or brightness on the screen, you can miss it. It can blend imperceptibly with the bone. So we see here a lesion of the proximal tibia, which is barely discernible. It's very permeative. You can't make out the borders of the tumor. There's a subtle reactive sclerosis. And I can tell you this patient was seen for many, many months without a diagnosis, and then ultimately developed swelling and a mass around the knee, and an MRI was performed, and you can see where the entire bone is replaced with disease. And that ended up being a lymphoma. In terms of soft tissue tumors, most malignant soft tissue tumors are actually painless. That's counterintuitive. One would think that a cancer growing in the soft tissues would be painful, but actually most soft tissue sarcomas are actually painless. They can occur in the deep soft tissues or even in the skin. Synovial sarcoma is one of the soft tissue sarcomas where approximately 50% of them are painful. Most patients recall an injury to the area followed by swelling, and patients can often have a long history of a stable mass. So just because a mass has not changed in size does not mean that it's benign. Sarcomas that occur in the popliteal fossa behind the knee are often misdiagnosed as Baker's cysts. And beware of hematoma-like masses. If you get an MRI or an ultrasound and it says that it's a hematoma, be very, very careful, because when you think of the amount of injuries that occur in the United States each year and the amount of fractures, very few patients actually develop hematoma-like masses. And there's got to be a high index of suspicion that that could be a high-grade sarcoma. And here's an example of an MRI of a hematoma-like mass that developed in a child who was a baseball player. He was a pitcher. He said he felt a twinge in his biceps, and there was a small lump there in the beginning, and that lump progressively grew but was painless. This is an MRI showing you a blood-filled mass, and this was misdiagnosed as a hematoma. It actually turned out to be an angiosarcoma. And part of the clue to it possibly being a sarcoma is this enhancement, a little bit more enhancement around the periphery here. Here's an example of an X-ray of an upper femur, and there's a very permeative lesion in it. The patient was having pain. The lesion is barely perceptible on the X-ray. It's also barely perceptible on the CAT scan, but the MRI, we can see a marrow replacing lesion in the proximal femur with some cortical thickening. The cortical thickening is somewhat detectable on the CAT scan, so you might be able to tell that something's going on, but certainly the MRI clinches the diagnosis, and this was biopsied. It ended up being a Ewing sarcoma, a rare type of Ewing sarcoma that is entirely intraosseous. 95% of them will have a soft tissue mass around it, but this was entirely intraosseous. So here's an example of a case of a 13-year-old male complaining of pain in the right thigh 3 days after a soccer game. So playing soccer, this X-ray was taken in the ER, and it was read as normal. But if you look at it very closely, there's this subtle indentation or scalloping of the bone in the diaphysis. Well, the child went on for some time complaining of pain and discomfort, and ultimately an MRI was performed that showed a mass that was not apparent on the X-ray in the soft tissues. And this mass, you can have actually malignant tumors that arise from the center of the bone, from the cortex, from the surface of the bone, or your soft tissue tumors. This was arising from the cortex or from the periosteum, and it turned out to be a Ewing sarcoma, and that went missed for probably about 6 weeks until the child had the MRI. So again, a high index of suspicion, and you should really be examining the patients for masses, palpable masses, and go the extra step and get an MRI if there's a high index of suspicion or radiological findings. And certainly if pain does not get better within 6 weeks after a patient states that they've had an injury and you've taken an x-ray and you don't see anything on an x-ray, the next step should be an MRI in 6 weeks. Always follow up with those patients. This is a field hockey player who was diagnosed with sciatica. One thing to keep in mind that sciatica can occur anywhere along the course of the nerve. The most common cause is from the lower spine, where you get a pinched nerve from a herniated disc or some narrowing of the foramina that clamp down on the nerve roots. But it can also occur from anything compressing the nerve in the pelvis. So it's very important when a person has sciatica to take a pelvic x-ray. If you look closely at the x-ray, there's very subtle sclerosis or subtle abnormality in the iliac wing. Very difficult to discern, especially if you have overlying bowel gas. But you look at the MRI and there's an enormous soft tissue mass around that iliac wing. And that turned out to be a Ewing sarcoma of the pelvis. These are all our different types of intraarticular tumors. So yes, there can be actually tumors that develop from the synovium inside of various joints. The knee happens to be one of the most common sites. And these are mostly benign, but there can be malignant tumors that develop inside an actual joint. PVNS, which is called pigmented villonodular synovitis, chondromatosis, which is a bunch of small cartilage lobules that develop in the synovium. They're sometimes referred to as loose bodies, but they're not actually loose. They're attached to the synovium. You can have synovial hemangiomas, which tend to cause pain and swelling. Lipoma arborescens, which is a big fatty mass in the knee or in a joint. Synovial sarcoma can develop in a joint. Clear cell sarcoma, which is also called melanoma of soft parts, can occur in a joint. Synovial chondrosarcoma, and there are others also. This top right photo is an example of pigmented villonodular synovitis. There are two varieties, a nodular variety and a diffuse variety. This is a diffuse variety affecting the front and the back of the knee joint. The diffuse variety notoriously recurs after it's removed, and there's different medications that you could use nowadays, and also radiation may be used to complement surgery and reduce local recurrence. But it's an aggressive tumor. It destroys the cartilage and the bone. And if left unchecked, there have been patients in, let's say, the 1960s where they ended up with amputations because of the aggressiveness of the tumor. It could also spread outside the joint and wrap around the neurovascular structures. Down here is an example of a hemangioma in an elbow. And this is the distal humerus. This is the olecranon fossa. And this is the hemangioma that was causing a pressure erosion in this child's olecranon fossa. Here's an example of a case which was initially read as pigmented villonodular synovitis on the MRI. This is the elbow joint, and it's very rare to have PVNS in the elbow. It's very common in the knee, the ankle, and the hip, but very rare in the elbow. This patient had been brought 3 times for arthroscopy of the elbow. And finally, the third time, there was a soft tissue mass that was developing into the joint. The first 2 times, there was nothing diagnostic obtained, but the biopsy of the soft tissue mass showed that this was actually a clear cell sarcoma. One thing that we don't do is we don't perform arthroscopies of tumors. When you perform an arthroscopy of a tumor, it floods the joint with fluid under pressure. And when you stick the scope in the joint, we use different instruments that chew up the tissue so it can spread the microscopic cells. And this patient actually ended up with various cutaneous metastases going up to the shoulder, ultimately a 4-quarter amputation, and then died of metastatic disease within 6 months after undergoing the 4-quarter. So it really complicates matters. So when I have tumors that develop in the joints, my first step is really to do an open biopsy of it, and then once it's diagnosed, then you can decide exactly how you're going to remove it. But most of the time, it's removed via an open approach so that other tissues are not contaminated and it's not spread systemically. Here's an example of an intraarticular synovial sarcoma. So this is the knee joint, this is the femur, this is the quadricep mechanism, and here's a lobular, somewhat lobular mass developing in the knee. Okay, you have to have a high index of suspicion that this is a synovial sarcoma. This was read as a nodular PVNS. However, it's a little bit large to be a nodular PVNS. You have to have a high index of suspicion. So a core needle biopsy can be performed directly into it, or an open biopsy. Another point is when biopsies are being performed, they should be performed by either the surgeon who's ultimately going to perform the procedure, or by a radiologist under the direction of the surgeon who will perform the procedure, because the trajectory of the biopsy has to be appropriately planned so that a limb-sparing surgery can be performed. If the biopsy is not performed appropriately, or if the neurovascular structures are contaminated, that could be a cause of a patient requiring an amputation instead of having a limb-sparing surgery. So just to reiterate those points, be wary of it performing any sort of arthroscopic removal of an intraarticular tumor. Arthroscopic removal contaminates the entire joint and the surrounding tissues and can disseminate it systemically. Here's an example of a patient who did have an arthroscopic removal of a tumor in their joint. This is an MRI of the knee. This is a sagittal MRI. And this tumor here, anteriorly here, this small nodular mass, was read as a cyst in the knee joint. You can see the axial section here. It's high signal on T2, matches almost the fluid signal of the fluid in the joint. Well, the surgeon went in and put an arthroscope in and began to chew it up, did get a biopsy sample, and the biopsy came back as a synovial sarcoma. And we can see the intraoperative photos here. There's sarcoma that's spread all over here, and it was studying the synovium. This patient ended up with an amputation and a very dramatic surgery when this could have just been opened up and removed very, very easily via an open approach and maybe had radiation. But again, many things on MRI can look similar. MRI is not diagnostic. And maybe 95% of the time, a tumor that looks like this may be a cyst. We have to keep in mind that tumors can grow and look very cystic, or could have cystic components to it, or hemorrhagic components, which can be misconstrued as a cyst or a hematoma. So again, a high index of suspicion and always approaching everybody very carefully. Here's a runner who was diagnosed with arthritis and told to have arthritis in their hip, and underwent a hip replacement. And it wasn't noticed that on the X-ray that there was this calcified material down here. This was thought to be osteophytes that broke off, or loose bodies from the osteophytes, and you could see the arthritis. The patient ultimately had a hip replacement, and then you can see on the MRI, this tissue was sent for biopsy and turned out to be a chondrosarcoma. Subsequent to that, the patient actually survived, but ended up undergoing a much more dramatic procedure than they really needed to undergo in order to eradicate the tumor. And actually, this patient was salvaged. The tumor did not come back. He was a patient of mine that's 20 years post-op by this point in time. Here's an example of a 15-year-old male who was lifting weights and felt a pull in the left groin. He was diagnosed with a muscle strain and observed for 4 months. This X-ray was initially taken, but I think that it was felt that this little lesion in his femoral head was a cyst. Ultimately, the pain persisted and the MRI was taken and turned out to be a chondroblastoma in the femoral head. So this is a lesion in the femoral head. There's a differential of various types of tumors that can occur in the femoral head. And intraosseous ganglion is one of those, but that would be a little unusual in a patient this young. Chondroblastoma in a skeletally immature patient is high on the list. Chondrosarcoma, clear cell chondrosarcoma, can occur in the epiphysis. Metastatic disease, myeloma, lymphoma, eosinophilic granuloma, infections can look like this, as well as osteoid osteoma and osteoblastoma. So that's a pretty complete list. And these tumors tend to occur in the epiphysis. So very important, have a high index of suspicion. One point is very important about pathological fractures. Make sure that, I always tell a patient when they have a tumor in the bone, equate it to a cavity in a tooth, right? If you have a big cavity in a tooth, you could bite on a piece of spaghetti and break your tooth, and you really shouldn't break your tooth on a piece of spaghetti. So patients with metastatic disease or tumors in their bones can break their bones doing seemingly normal activities or having very minor trauma. So you have to have a very high index of suspicion if somebody breaks a big, thick bone with minimal trauma. So this is a patient where pain was dismissed for months, was thought to have a stress fracture. Patient was a runner, was treated with non-weight bearing, and patient was stepping off the bus. So when they stepped down, they completely fractured their femur. When they ended up in the emergency room, they underwent an open reduction internal fixation, which you see here on the left, that was monitored and wasn't healing. So it was thought to have an infection, underwent several irrigation and debridements, and had this antibiotic spacer placed, only to find out that this was ultimately pathology sent after a few washouts to find out that this was a clear cell chondrosarcoma that was developing in the bone, and the patient ended up with a hemipelvectomy, which possibly could have been avoided on the outside when they had a minor crack in the bone. This is a pitcher who fractured their humerus while pitching. Initially, they were casted because there was no lesion detected on the x-ray. You can see it's very permeative. I'm not sure if you look very closely, you can see a little lucency throughout the bone here, but it wasn't suspected that the person had a lesion in the bone. And I think everybody has seen some famous baseball player pitchers on the mound and throw a high-speed pitch and fracture their bone. Most of the time, that's through an actual cyst. There's been a couple players who've had myeloma, and in the childhood and adolescent age, you have to be highly suspicious of a bone sarcoma, which can be very permeative in nature, doesn't look anything like a cyst, and where you can't make out the borders, and can almost look like just a little bit of osteopenia in the bone. Here's a runner with a stress fracture in their fourth metatarsal. Right, here's the oblique views. Again, this was dismissed as a stress fracture for a while. It wasn't getting better. An MRI was performed, and a lesion was identified, which turned out to be a Ewing sarcoma. Now, granted, a very rare location for Ewing sarcoma. Most Ewing sarcomas should occur in the femur, the tibia, or the humerus, the big bones in the body. But again, a high index of suspicion. If you go back to that x-ray, you could see this sort of diffuse osteopenia or osteolysis, which may have been attributed to disuse. However, you look at the rest of the foot, the rest of the metacarpals, and you don't see any disuse osteopenia in it. So that should raise a high index of suspicion that something else could be going on in the bone there. This is what I call double crush. So this patient, so meaning that you can have two things going on at the same time in different body parts, actually. This was a teenager. He tore his rotator cuff and had his rotator cuff repaired. And 6 weeks later, went back to the surgeon after they were starting physical therapy. and was actually complaining of knee pain. Now, this was an extremely astute surgeon. He did not just dismiss it. Some doctors may just say, "Hey, you're leaning on one side, or you're walking a little awkwardly because we just did your shoulder and you're leaning, or you're favoring your leg." We got an X-ray, and what we saw was a permeative lesion in the proximal tibia with this fluffy cloud-like density, right? So this fluffy cloud-like density is actually a sarcoma making bone. And the MRI was performed. This was biopsied. It turned out to be an osteosarcoma. So it has a malignant appearance. Malignant tumors blend imperceptibly with the bone. In other words, you can't make out the beginning or the end of the tumor. They permeate through the bone. And an osteosarcoma is called an osteosarcoma because the tumor itself is making bone. It's not called an osteosarcoma because it occurs in bone, but it's because it's making bone. Our three most common bone sarcomas are osteosarcoma, chondrosarcoma is number 2, and Ewing sarcoma is number 3. Osteosarcoma and Ewing sarcoma are the two most common in childhood and adolescence. Chondrosarcoma usually occurs above the age of 40 or 50, more common in the adult population. This is a 40-year-old female runner who felt a pull in her thigh during a marathon. She was having some pain in the knee area, underwent an X-ray of the knee, and was diagnosed with a tear with a hematoma and heterotopic ossification that formed in the muscle because of the tear and the bleeding. 1 year later, approximately 1 year later, she was persisting with pain and severe swelling, and this X-ray was taken a year later, and we can see how large this mass grew. And this turned out to be a very heavily mineralized, heavily ossified synovial sarcoma. And the patient ultimately lost her leg and passed away of metastatic disease, and treatment was delayed for a year. This is not heterotopic ossification. Heterotopic ossification should have almost a hollow appearing area inside of it. Again, when you see things like this, take the next step and work it up with an MRI or some sort of advanced imaging like a CAT scan. And this is a 16-year-old female with pain in her anterior knee after running. She was running, she stated that the knee swelled immediately. You have to remember, a lot of times patients' histories are not accurate. Sometimes because masses are growing, they're painless usually. The malignant soft tissue sarcomas are painless, so they might not be noticed. Granted, they could be injured while running, or they could hemorrhage into it and become larger. Well, on MRI, this patient was, because of the history she gave, was diagnosed by the radiologist as a quad tendon rupture with a hematoma. The surgeon went in and cleaned out this area, spread it all over, and she ultimately ended up with a very high above the knee amputation, almost a hip disarticulation, and died within a couple of years afterward of metastatic disease. So we have tumors that also can have a cystic appearance on an MRI or on an ultrasound, or can be located in areas where you may think it's more likely a cyst. So, and the types of tumors that often do that are synovial sarcomas. They could have a very large cystic areas associated with them, and myxoid sarcomas. Myxoid sarcomas are sarcomas that produce a mucus-like substance, right? Mucus has a lot of mucopolysaccharides which hold on to fluid, hold on to water, or hold on to fluid. And on an MRI, fluid shows up very bright, just like a cyst. As you can see on here, this T2, or this fluid-sensitive sequence on this MRI. And we have various types of myxoid sarcomas, but the two most common are myxoid liposarcoma and myxoid fibrosarcoma. This is a patient that had a mass develop around the ankle. On physical examination, it was thought to be a ganglion cyst. An attempted aspiration was performed several times over 3 to 4 months. They finally couldn't get an aspirate, so they decided to do a cord needle biopsy, and it came back as a synovial sarcoma. He was able to salvage the child's leg, but by the time the child made it to me, they had developed metastatic disease, and they ultimately passed away within a couple of years. So just a point about soft tissue sarcomas in children, right? The two most common bone sarcomas are osteosarcoma and Ewing sarcoma, and the two most common soft tissue sarcomas in children and adolescents are synovial sarcoma and rhabdomyosarcoma. In the adult population, chondrosarcoma is the most common bone sarcoma, followed by undifferentiated pleomorphic sarcoma bone. That used to be called malignant fibrous histiocytoma bone, or MFH bone. And the most common soft tissue sarcomas are liposarcoma, undifferentiated pleomorphic sarcoma. Undifferentiated pleomorphic sarcoma is more common in the soft tissues than in bone, and then synovial sarcoma. Here's an example of a myxoid liposarcoma in a patient, right? This is the T1 weighted image. The T2 or fluid sensitive images are in the middle here and over on the right. Right, your T1 shows a mass here that looks like it's connected to the joint, and the mass is similar in signal to muscle. And the T2 shows a very bright fluid-containing mass with almost a tail coming out of it, heading toward the joint. This was diagnosed as a ganglion cyst of the joint, right? The only way to tell definitively if it's a ganglion cyst is to administer contrast dye. A tumor should have some contrast enhancement, whereas the cysts will not. And actually, anything that is suspicious should then be biopsied, either needle or open. Here's an example of a tumor that was dismissed as a Baker's cyst. So this is a patient who's very, very active in sports, track star, and they had a mass develop behind their knee. Went to the doctor, was palpated, said, "Oh, you got a Baker's cyst." Was left alone for months, went undiagnosed. Finally had an MRI and was sent to a specialist and diagnosed with a sarcoma, a soft tissue sarcoma. And you can see it's right in the spot where it could be easily misconstrued as a Baker's cyst. Remember, when you examine a Baker's cyst on physical examination, if you flex the knee, the mass should disappear. So you should feel the mass disappear and be not palpable. Anything that does not disappear should be very, very suspicious as being a potential tumor or malignancy. So what are my recommendations for you for patients that you see in the office? Anybody who presents to you with pain in the joint or an extremity, please x-ray them, okay? X-ray anybody with pain or with swelling and give them a good physical examination. Palpate the painful areas and always have in your mind that a mass or a soft tissue mass or a tumor can be part of your differential diagnosis. See patients back in the office within 6 weeks to see if pain and swelling has improved, especially if the initial x-ray is negative. You should perform an MRI with gadolinium on all palpable masses that are suspicious, or when the pain has not dissipated, go that extra step, right? Tumors that you may think are cystic in nature, if they're close to the surface of the skin, should transilluminate with a flashlight, and it doesn't hurt to put a needle in it. But again, biopsy should be planned ultimately by the surgeon who's going to perform the definitive procedure. Don't presume a mass is a lipoma just by palpation, right? Many of the different types of sarcomas can be soft in nature, or sometimes a mass is arising deep from the muscle, and you're only feeling the tip of the iceberg, to say, and you think that it's a lipoma under the skin. So don't just presume it's a lipoma. If you do think it's a subcutaneous lipoma, make sure that it's mobile. You can palpate it with your fingers and feel it in between your fingers, move it around. And but I usually MRI most of them because I've seen many people dismiss as lipomas. It can have a soft texture to it when you're palpating it and end up being a type of sarcoma. If a patient has a previous history of a cancer, please get a bone scan. Right, patients who complain of bone with bone pain or pains in their joints with a previous history of cancer should get extra imaging, either a bone scan or an MRI. You always have to have that cancer in the back of your mind as possibly being the cause of the pain. Be very suspicious of hematomas, cystic masses, and Baker's cysts read on MRIs or on ultrasounds. Ultrasounds are notoriously inaccurate for evaluating soft tissue masses, right? They have maybe, if they're lucky, a 50% accuracy rate in determining if something is solid versus cystic, or something is a lipoma versus not a lipoma. And always consider a tumor as a potential cause of pain. Remember, patients could have injuries and see a tumor on a scan, and it could end up being a serious tumor. Send them for the appropriate referral or for advanced imaging. Thank you very much. We're going to take any questions now that you might have.
All right. Thank you, Dr. Wittig, for such a fantastic talk. Our chat box is open and full of questions right now. If anybody else has any questions, please put them in the chat box and I'll read them out loud. The first question that came in says, if a patient presents with very vague symptoms that don't seem to be bothering them too much, but enough to annoy them, how long would you let it go before ordering more advanced imaging?
Well, it depends a little bit on the age of the patient, but my general rule is if a patient is complaining of a vague type of pain, right? If it's a child, right, you have to remember children can have referred pain. So children who have something going on in the hip can present with knee pain. They could have something going on in their knee and present with hip pain. So you have to at least start with an x-ray. And if it's a child, make sure you get an x-ray of the joint above and below the area of concern. Try to evaluate it and see if the pain is suggestive of nerve type pain or radiating pain that could be stemming from the back of the pelvis down in the extremity or from areas around the brachial plexus. Same thing in adults. Similar, very good physical examination, palpate the area, range the joints, determine the nature of the pain, x-ray it. And if those patients, you should always have those patients follow up with you, whether it's coming into your office or having your nurse calling them and documenting that the pain goes away within 6 weeks. If not, then it's now time for advanced imaging. That usually includes an MRI of the area. Sometimes if there's a previous history of cancer, you'll go the extra step and get a bone scan on top of the MRI to rule out any other areas or mets or things that may be occurring in other areas and producing radiating pain.
Great. Thank you, Dr. Wittig. The next question involves nutrition in your cancer patients. I think this ties into some of the pathological fractures that you showed in some of the cases that you just had up on the screen. So the question is, how does nutrition play a role in cancer patients?
Nutrition plays a very big role. Patients are going to have to undergo various treatments, and let's separate the children from adults. Adults with metastatic disease, right? It's usually a progressive downhill course. Even patients with metastatic breast cancer to bone only, approximately, patients with breast cancer to bone only, they have a slightly better prognosis, but still patients with about 60% of patients will die within 5 years. And usually there's problems with their metabolism that come up. They're going to get radiation and chemotherapy and other treatments. Children with bone sarcomas or soft tissue sarcomas will also get radiation and chemotherapy. So very important in terms of going through the chemotherapy process or the other treatments to keep the nutrition as optimal as possible. And then the surgeries that the patients undergo, they're very large surgeries, right? It's important to try to get the nutrition optimized as much as you can prior to the surgery. So we encourage a lot of protein intake, a lot of amino acid intake prior to surgeries, which will help maintain the strength and maintain the structures of your bone and your muscles, which will ultimately help you recuperate better after surgery or get through those other treatments better.
Great. Thank you, Dr. Wittig. The next question is, what on physical exam would be more likely to be a malignant tumor versus a benign one?
So it's interesting. We're all taught in medical school, I think, when we're talking mostly about carcinomas, that carcinomas, if you're examining, let's say, a breast, that carcinomas are very firm and rock hard, and that there's no motion, right? When you go to move it, that it's firmly fixed. Sarcomas are a little bit different. Soft tissue sarcomas that occur in the extremity can occur in a muscle. And when you go to move that tumor back and forth, it moves usually fairly freely. It's not completely mobile. The muscle will move with it, but it is more mobile than, for instance, carcinomas that develop in other glandular structures or the breasts or the thyroid, etc. The malignancies are usually firm. A bone malignancy or soft tissue sarcoma will be fairly firm. Actually, a bony malignancy, if it's stemming from the surface of the bone or the medullary canal, will not be mobile. But usually they're not tender. Bony malignancies, they'll complain of pain, but they're not tender. A soft tissue sarcoma is usually not tender either. And usually patients have pretty good range of motion of their joints above and below the areas of the cancers. So it really requires, again, a high index of suspicion. And again, because soft tissue sarcomas are usually painless, it's very counterintuitive. You would think that a cancer developing in the muscle is going to be painful, but it's not. It's a painless mass, which often gets dismissed as like a muscle pull or a knot in a muscle.
Great. Thank you, Doc. The next question goes over systemic symptoms that could be seen in either a malignant or benign tumor. Do these patients with benign and malignant tumors present with unintentional weight loss?
Patients, this is interesting because there's patients with sarcomas, the primary musculoskeletal tumors, rarely ever present with any systemic signs or symptoms or any abnormalities in their blood work. Occasionally, a patient with osteosarcoma will have a high alkaline phosphatase, and a Ewing sarcoma may have a high LDH. But usually there are no systemic signs and symptoms, usually no weight loss and no fevers. Usually there's no overlying erythema over them, but there may be overlying venous dilatation from the venous shunting. Carcinomas, on the other hand, may be more metastatic carcinomas, more associated with cachexia, weight loss. I don't see too many patients with metastatic carcinoma to bone that have fevers. I have seen some patients with lymphoma, but then again, most patients who present to me with lymphoma, they really don't have night sweats or weight loss.
Sure, Dr. Wittig. So we were going over the multidisciplinary approach to
Yeah, so it's very important to refer the patient for the biopsy so that the biopsy is performed either by the surgeon who will ultimately perform a limb-sparing surgery or by under their direction, working with a radiologist to do a CAT scan guided biopsy and direct it at the area of the tumor and make sure that it passes through the appropriate surgical planes. 95% of patients with sarcomas nowadays can have their limbs spared and not amputated. And the leading cause of a patient requiring an amputation at least in these areas, are inappropriately performed biopsies. So when you perform a biopsy of a soft tissue sarcoma, if you're going to perform an open biopsy, the incision always has to be longitudinal, not transversely across the extremity. And certainly we plan out needle biopsies or core needle biopsies. FNA is also very inaccurate in evaluating musculoskeletal tumors. It's got about a 50% accuracy rate from determining benign from malignant musculoskeletal tumors or mesenchymal tumors. So it's usually core needle biopsies that are performed. And then subsequently, we work with our medical oncologist, pediatric oncologist, radiation oncologist, or pathologist, or radiologist as a big multidisciplinary group discussing cases, discussing patients' treatments once we get the diagnosis.
Thank you, Dr. Wittig. If anybody else has any other questions, you can put them in the chat. We have one more question to go, but we do have some time left. Dr. Wittig, what imaging studies should you get on the patient prior to consulting you? And I'll add on that a little bit. When the patient does see you, what imaging studies do you order, and in what order do you order them?
So I think the most useful studies are probably the X-ray and the MRI. And the X-rays are even useful for evaluating a soft tissue mass because we look for calcifications in various types of soft tissue masses. Certain soft tissue masses can show up in different ways on X-rays. And we also look for any underlying bony erosion on X-rays. MRI is also very useful to evaluate the extent of the tumor, but the differential diagnosis of a bone tumor is made on the X-ray, and MRI is not. There's very few things that you can actually diagnose on an MRI. Let's say a lipoma is diagnostic, a schwannoma, a hemangioma, and sometimes fibromatosis is very diagnostic on an MRI. Everything else is not necessarily diagnostic, but it can help you support in determining if something's benign versus likely malignant. And, soft tissue sarcomas, high-grade soft tissue sarcomas show up on an MRI as a very large heterogeneous mass or a cystic appearing mass, which ultimately requires a biopsy to diagnose it. So ultimately, of course, the diagnosis ends up in a biopsy. Sometimes I will order a CAT scan of the mass if I'm looking for subtle mineralization or some other features that might help me narrow down the diagnosis before I perform the biopsy, because the biopsy is always correlated with your actual radiology studies. Bone scan is useful. The most common sites of metastases for bone sarcomas and soft tissue sarcomas are the lungs and the bones. So bone scan is often useful. Sometimes for various types of tumors, we'll order a PET scan. And especially for patients undergoing preoperative chemotherapy, we'll order a PET scan before and after the preoperative chemotherapy to look at the response in the tumor to the chemotherapy, which helps us make some judgment decisions during surgery, or sometimes if it's a very, very large mass, whether we're going to need to perform an amputation or we can save the limb. And the majority of times we'll be saving it. But I think that those are and actually since it goes to the sarcomas travel to the chest, a CAT scan is useful. But to start off with, before, sending the patient to me, always X-rays and an MRI are what's most useful to come from a primary care doctor or a family physician.
Great. Thank you, Doc. We have one more quick question coming in. How would you evaluate a painless sternoclavicular mass in an adult?
So sternoclavicular masses, there's some conditions that happen of the sternoclavicular joint. And the majority of time, it's an arthritic type process called osteitis condensans. Normally, you would start with an X-ray and see if you see any lysis there or see a lesion developing in either the sternum or the clavicle. If that's not conclusive, then, conclusive for the next step is really an MRI Sometimes CAT scan can be helpful. They're also looking for subtle sclerosis or deterioration of the joint. But often what happens is the clavicular head becomes enlarged in those situations, and the patients present with a painless mass. Now, other things you have to think of are infection when it comes to problems with the sternoclavicular joint, but usually that's going to be painful and probably hot. And there are rare types of tumors that come up from the medial part of the clavicle. In the younger population, aneurysmal bone cysts and giant cell tumors can arise from there. And in the older population, you do have to think about Mets, myeloma, and lymphoma. So usually Mets, myeloma, lymphoma are going to be painful. But again, go to your advanced imaging. That could be a very difficult area to evaluate on radiographs. And certainly getting an MRI or getting a CT is justified. And then you take it from there.
Great. Thank you so much, Dr. Wittig. And thank you again for taking the time tonight to educate us on musculoskeletal tumors. On behalf of the Morristown Medical Center Orthopedic Department, I would like to thank you all for your participation in today's event. This concludes today's program. Thank you and have a great evening.
Thank you, everybody. Thank you for coming and listening to the webinar.